So as people think about the concept of early treatment or treat to target, one of the issues that comes up is how early in the disease course should highly effective therapies be used. And I think for many of us that becomes kind of a risk stratification. We've talked about that earlier in the program with some of the other speakers, that you really want to pick the patients who are low risk and have mild to moderate disease, and those patients might be well treated with a tapering course of steroids and careful observation. But about 2/3 of patients are more in the high risk, moderate to severe category. They tend to have a progressive destructive course that leads to complications of disease and fistula, stricture, abscess, and surgery. And the only way to prevent those complications is to heal the bowel early. And the best way to heal the bowel early is to introduce a biologic, often in combination with an immunosuppressive, early in the course. So my personal thinking is to risk stratify the patients, and about 2/3 of the patients will need early combination therapy.
So I think it's important to recognize that if you take 100 patients, and if we have information that suggests that about 80 to 85% of patients will have a moderate to severe prognosis, meaning risk of complication, it means that if we treated everybody efficiently with a biologic, and I'm not proposing that, but I'm making that overarching thought that you could say, that would mean we would overtreat 15 to 20% of patients versus maybe undertreating 80 if you treated everybody alike. So I think what we're beginning to see is that by being able to decide upfront that this patient has risk factors that will determine their prognosis to be at risk of a complication, especially Crohn's patients for perforations or stricture. And therefore, if we know that we have a select window of opportunity, we say, look, when we communicate with patients, this is what your risk looks like, maybe through a visual tool and or just in communication. And we feel that if we could target your mucosa early, and we know that mucosal healing rates are much better if you don't have bowel damage, obviously, so you get a bigger bang for your buck. So you want to invest up front and be able to say, I'm going to stratify you to be someone that's going to complicate. Therefore, I want to give you the most effective therapy. In a patient who may not be a high-risk patient, which again is not a lot of our Crohn's patients, then you may be able to do somewhat of a step up or accelerated step up, or maybe nothing. I mean, who's to say that our treatments actually change the trajectory in patients who aren't projected to complicate? That's provocative in some way what I'm saying, but the idea is maybe some of the future therapies, maybe microbial-based therapies, or dietary interventions may be okay for those patients who don't complicate or aren't predicted to. So when I have a patient who sits in front of me who wants to use diet or some kind of complementary alternative medicine approach, because there's much more on the web about how dirty our meds are and how unsafe they are, but how safe this tree bark or herbal diet that for Crohn's, and it cured patient X, right, or Mr. X. And of course you want to have control over the therapies. You read about these therapies, you're worried about the safety of these therapies, therefore you want to hold on to the idea, is there some kind of natural way I can control this inflammation? It could be that in that small subgroup of patients who are not predicted to complicate, those are the patients in whom diet or microbial based or herbal or whatever ends up being what it is would be effective. So I no longer dismiss the idea that in some patients there are non-classic therapeutic approach, and so therefore working with patients and explaining why risk stratification is important, which comes back to this idea that treatment needs to be tied to risk, and getting patients to understand that their Crohn's is different than maybe their aunt's Crohn's or the first cousin of the first cousin. You know, there's a large family trees that expand, and people integrate their experience and think that their Crohn's may mimic someone who may be genetically related, but it's not necessarily the case because the environmental trigger may be different, the microbiome may be different. And so trying to hone in that it's your Crohn's disease and your personalized treatment plan, I think helps us develop this communication and engagement and empowerment of patients to say, I know what my disease is supposed to look like. Even if I'm off by 10%, meaning if I'm predicting it wrong by a little bit, it's not quite 80% chance of stricture, but it's 68%, it's still more than 50 and it's still more than 20. And developing that collaboration with the patient to help them understand that we are working together, we are both on the same page. We may come at it differently, but let's meet in the middle. And that's how you're going to be able to go to the next step with patients, is to really understand risk stratification with the patient, make it personal and tailored and customized, this whole precision IBD, the aspect of precisely and robustly monitoring a patient and diagnosing them and treating them. And I think being able to decide that this is a high-risk patient, therefore I'm going to go with this strategy. I may be overreacting, and the patient and I need to realize that this is what we got right now, and we're making our best guess at changing your life. And I think that's really where the treat to target comes in, is we've been so focused on our target that we haven't asked the patient what their target is. And if we can somehow tie our target of mucosal healing to their target of having a normal quality of life and disability, it's a win-win for all stakeholders.